بسم الله بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. ونصلي وسلم على خير خلقه محمد وآله الطيبين الطاهرين ومن تبعهم بإحسان إلى يوم الدين. Dear colleagues, thank you very much today for attending this meetings, which is quite an interesting topics. And in fact, the diagnosis and management of immune complex MPGN and C3 glomulopathy requires comprehensive approach utilizing kidney biopsy, immunofluorescence, microscopy, complement workup, genetic testing, and evaluation of non-complement etiologies, especially in the context of immune complex MPGN. Addressing the unmet needs in differential diagnosis and therapeutic option remains a priority, with ongoing research paving the way for potential targeted treatments that could revolutionize the management of those complex glomerular disease. And today we have three colleagues, eminent speakers that will be talking with our colleagues and sponsored by our pharmaceutical company SOBI for their great effort to further expand the education and indeed the proper management of our patients. And first of all, I think we'll start with Dr. Ali. I know Dr. Ali for quite a long time now, Ali. Ali is one of the smartest guys I know. I remember since student graduating with distinction from Sultan Qaboos University and then pursue his further training in Canada. And of course, now he's our senior consultant at the University, Sultan Qaboos University Hospital. So the floor is your Ali. تفضل حبيبي الله يحفظك.
Thank you very much, Dr. Issa. I appreciate the kind introduction. So, Assalamu alaikum, everyone, and welcome to today's talk, which, as Dr. Issa already mentioned, is going to be about C3 glomerulopathies and immune complex MPGN. Insight into diagnosis and treatment. Disclosure, as you already know, this talk is sponsored by SOBI. So this will be the outline of my talk. First, a little bit of pathophysiology on C3G and primary immune complex MPGN. We'll move then to the clinical features of the two conditions, treatment guidelines, unmet needs, and then we will spend a bit of time talking about a promising drug in the management of these not so easy conditions to treat and rare conditions, including a phase 3 trial, which has already been complete. So I'm sure most of the audience here, actually, when they learned about immune complex MPGN and C3 glomerulopathies, learned it as, MPGN type 1, 2, and 3. That was the old classification, and it was based on histopathological features. And the main problem with MPGN type 1, 2, and 3 is that it didn't really tell us about the underlying etiology of the MPGN, except for type 2, which was dense deposit disease. But otherwise, there was really no distinction between the different etiologies of MPGN. So more recently, we are actually using the new classification, which is C3 glomerulopathy, when we only see C3 deposition in the kidneys on immunofluorescence without any immunoglobulin. And C3 glomerulopathies can be either C3GN or dense deposit disease. And then the other category is the immune complex MPGN, in which you see similar features, but this time on immunofluorescence, you have C3 deposition with immunoglobulin and or other immunoglobulins and complement as well, like IgM and C1q deposits. So we'll talk a little bit about the pathophysiology of C3Gs and primary immune complex MPGN. So for these conditions, while the triggers are heterogeneous and we don't always know what really triggers them, complement dysregulation appears to be the primary pathophysiology pathophysiological driver of the disease. So I'm sure you can all see this graph on the slide. So this is the alternative pathway, which is one of three complement pathways that we all have, the other ones being the classic and the lectin pathways. So what's unique about the alternative pathway is that it's always active at low grade. It doesn't necessarily require a trigger, okay? So it starts with C3, which actually undergoes spontaneous hydrolysis, and then C3 combines with factor B and propyridine, and factor D actually aids with that as well to ultimately form something called C3 convertase. And what C3 convertase does is that it actually creates an amplification loop. So where it goes back to the previous steps and the whole thing, gets amplified, it becomes like a vicious cycle. And then in addition to that, C3 convertase goes downstream where it actually forms the C5 convertase that ultimately converts C5 to the C5b, which then gets assembled into the membrane attack complex. So what causes this complement dysregulation? So there are genetic mutations which have been associated with C3Gs, and they are identified in up to 25% of the patients. And we have to recognize that the type of mutations, there are two main types of mutations. It can be either a gain of function mutation or a loss of function mutation. What does that mean? So if you remember when I said that the alternative pathway is always active, it actually does have some natural breaks to allow it from, becoming pathological and leading to disease. But sometimes we have actually mutations in these natural regulators like factor H, factor I, MCP, membrane cofactor protein, CR1, and then DK activating factor, and that actually results in the complement dysregulation. Or we can actually have a gain of function in complement activators, for example, factor B, factor H-related proteins, and C3 as well. The other triggers for alternative pathway dysregulation are actually acquired antibodies. So autoantibodies can be found in up to 50% of cases of C3G, and examples are mentioned in the table here. The most common ones would be like factor H antibodies, C3 and C5 nephritic factors. Moving to the next part of the talk, which is clinical features and diagnosis. So first of all, C3Gs and immune MPGNs are actually ultra-rare diseases. So the incidence of C3G is estimated to be 1 to 3 cases per million per year. And in the case of C3G and the prevalence of C3G and primary immune complex MPGN in Europe is 1.3 cases per 10,000. So really rare. How do these present? So the presentation is fairly typical of glomerulonephritis, but here actually you can actually have a full spectrum of presentation. Some patients present just with asymptomatic hematuria and proteinuria, and patients can actually present on the other end of the spectrum with severe and advanced chronic kidney disease, and even end-stage kidney disease, as I will talk about my patient later in the presentation. Other associated findings on presentation can be low serum C3, which is present in more than 50% of the patients, retinal drusen, and then partial lipodystrophy. How do we diagnose and work up patients with C3G or primary immune complex MPGN? So as I said earlier, patients present with proteinuria, hematuria, edema, hypertension, and renal dysfunction. So typical picture of a nephritic syndrome. So obviously always have to send, the ANA, ANCA, anti-GBM complements. And then these patients all end up being biopsied. So once you have features of MPGN on the biopsy, then immunofluorescence helps us distinguish if it's C3G or if it's an immune complex MPGN. And then once we have that, we have to do all the additional workup to rule out all the secondary causes of C3Gs and primary immune complex MPGN, which I'm sure all of you are familiar with. And that actually includes hematological malignancies or monoclonal gammopathy, so plasma cell or B cell dyscrasia, infections. The most common one would be like hepatitis C infection, and then autoimmune disease, including lupus. And if it's a picture of pure complement-mediated MPGN, like C3Gs, then we also have to test for complement dysregulation and autoantibodies, because some of these actually, in addition to helping us with the diagnosis, may have therapeutic implications as well. So moving to the treatment guidelines. So how do we treat somebody with C3G or primary immune complex MPGN? So we always, in nephrology, like to start with conservative management unless contraindicated. Conservative management includes RAS blockers. More recently, we have SGLT2 inhibitors, blood pressure control of their edema, either pharmacologically with diuretics or non-pharmacologically with salt restriction. And then patients who do not respond to conservative management alone, then we move to immunosuppression. So when is immunosuppression indicated as per the guidelines for C3Gs? It's actually when patients have a proteinuria of more than 1 gram per day. Some people say 1.5 grams per day, nephrotic syndrome, or declining renal function. And what treatment options do we have? So here I have to emphasize that I'm not talking about those that present with a picture of RPGN, because those with RPGN, like any type of GN, you will immediately start immunosuppression without conservative management. So here, the first-line treatment is glucocorticoids and mycophenolate mofetil. And actually, if you look up the evidence behind steroids and MMF and the treatment of these conditions, it's actually, poor quality evidence, basically. It works for some patients, but there's no strong evidence behind it. Now, what happens to the not small percentage of patients who do not respond to the first-line treatment? Then the guidelines recommend either eculizumab, which is a terminal complement blocker, or consider enrolling them in a clinical trial when feasible. Now here, I just wanted to show, because I was reviewing the evidence for eculizumab in C3 glomerulopathies, and I was actually quite surprised that it's not really great. There are no randomized control trials. The evidence mainly comes from retrospective studies and case series. And this is probably the largest one that's available, which is a French case series for 26 patients with rapidly progressive GN secondary to C3G. So they were given eculizumab, and the response was basically a quarter of them responded well. Another quarter, things stabilized but did not really improve. And actually 50% of them did not respond to the eculizumab. So their conclusion was it appears to be a potential treatment for crescentic RPGN C3GN, but its benefit in patients with non-RPGN seems to be limited. And then I found another actually study of 11 patients. As you can see, the numbers are very small because it's a rare disease. And here also the conclusion was the benefit of eculizumab in chronic progressive C3 glomerulopathy is limited. However, it's there in the guidelines because we have to remember that it's a rare disease. It's a very serious disease, and therapeutic options are limited. And, we use it as some kind of a rescue therapy. So during my talk, I've already discussed several unmet needs with these conditions. So first of all, the disease is very rare. The presentation is heterogeneous. The symptoms can very much actually be attributed to something else, and people tend to forget about the possibility of GN in general. I can't tell you how many times young men with hematuria and proteinuria were labeled as UTI and were given antibiotics, and nobody actually considered the possibility of GN. So that's I think, a major obstacle. In terms of diagnostic test, as mentioned earlier, there's actually a long list of a battery of tests that are required for these diagnoses, including referral tests that are not available readily. And actually, I've included this table. I know it doesn't project well, but this is actually a table of all the centers worldwide that actually do the complement dysregulation testing. And there are only 18 of them worldwide. Another challenge is actually a referral for kidney biopsy. That's not always something easy and accessible everywhere. Histopathological analysis and confirmation of the diagnosis, and so on and so forth. Another major challenge with these conditions, and an unmet need as well, is that up to 50% of patients with these conditions actually progress to end-stage kidney disease within 10 years despite treatment. Obviously, that doesn't sound good at all. And in addition to that, these patients, when they get transplanted, they have a very high risk of recurrence, ranging anything between 60 to up to 90% in some studies for dense deposit disease. So patient treatment needs, in summary, we need effective symptom control, modified disease course, reduced risk of transplant and recurrence post-transplant, minimization of treatment-related side effects, and accessibility and convenience of new therapies, which moves me to the last point of my talk, potential novel therapies. And before I start talking about pegcetacoplan, wanted to mention something because that's relevant to the main trial for pegcetacoplan, is that there is the Kidney Health Initiative, a group of experts actually met, and they agreed on what are the logical and reasonable endpoints for trials that study new novel drugs for C3 glomerulopathy. And actually, what they came up with was proteinuria reduction, which makes sense. It's there for every nephrological condition. eGFR stabilization/improvement, which is also there. But what's relatively new is histopathology improvement, as I will talk more later. So what's pegcetacoplan? So pegcetacoplan is a targeted C3, C3b inhibitor, which is designed to control C3 overactivation. It's a pegylated drug, which makes it long-acting, and it's currently being investigated as a therapy for C3G and primary immune complex MPGN once you've ruled out every possible underlying cause. So currently, pegcetacoplan is indicated by European Medical Association for the treatment of patients with paroxysmal nocturnal hemoglobinuria, which I'm sure all of you know is another complement-mediated condition. So they reserve it for patients who continue to be anemic despite being on a C5 inhibitor like eculizumab or ravulizumab for at least 3 months. But actually, the FDA has approved it for anybody with PNH. And some of you may be familiar with the Pegasus trial, which was published in New England Journal of Medicine for PNH, which was a head-to-head trial between pegcetacoplan and eculizumab. And it showed that pegcetacoplan was non-inferior, but it was also advantageous in certain aspects, such as anemia. So hemoglobin was better in the pegcetacoplan arm, as well as fatigue. So how does it work? So pegcetacoplan binds to C3, preventing C3 convertase from converting it into C3a and C3b, which are involved in inflammation and opsonization. And then pegcetacoplan also binds to C3b, preventing it from integrating into C5 convertase complex. So unlike the terminal complement blockers, this actually works more proximally and at 2 different levels. And by doing that, it inhibits glomerular deposition of C3 breakdown products to prevent inflammation and renal injury. So what data do we have that supports pegcetacoplan? We have in total 4 trials. VALE, we don't have data yet. It's a long-term one. Discovery and Noble were actually phase 2 trials, and now we have Valiant phase 3 trial, which was actually presented in the last ASN in October 2024 as a late-breaking trial. So we'll start with the Discovery phase 2 trial. So it was an open label, and it was to evaluate safety and, a biological activity of pegcetacoplan, like a proof of concept. And they actually included various complement-mediated glomerulopathies here. They had a total of 8 patients that received pegcetacoplan for 48 weeks, and their primary endpoint was the change in proteinuria at 48 weeks, and they had a few secondary endpoints as well. So as you can see, these are the patients, and actually all of them exhibited a reduction in proteinuria at 48 weeks. So the baseline was, in fact, nephrotic range proteinuria, and by week 48, it was less than a gram per day. eGFRs did not change, but we have to keep in mind that this was a short-term study. You don't expect to see eGFR changes so soon. And then C3 levels also improved for patients who received pegcetacoplan, as you can see in this graph, as well as other markers of complement activity, including membrane attack complex. So the baseline was 1,113. At the end, it was 385. In terms of safety endpoints, there were no discontinuations because of serious adverse effects, and the majority of adverse effects were considered unrelated to the study drug, and there were no deaths reported. Next is the Noble study, which is also a phase 2 study. Here they had 13 patients, and they actually all had recurrent C3G or immune complex MPGN post-transplant. Again, they received pegcetacoplan initially divided into standard of care, or pegcetacoplan was standard of care for 12 weeks, and then everybody received pegcetacoplan. Here, the primary endpoint was C3 staining reduction at week 12. So they had protocol biopsies at week 12. So as I mentioned, age more than 14 included, and clinical and pathological evidence of recurrent C3G or immune complex MPGN transplant. Important to mention here that everybody had to be vaccinated. Remember, this is a complement blocker. Main concern with complement blockers is infection with encapsulated organisms. So actually all trials on complement blockers, everybody has to be vaccinated against Neisseria, strep pneumonia, and Haemophilus H flu. This is basically baseline characteristics of the patients. Most of them had C3G. Minority had immune complex MPGN. And then if you look at the C3 staining at week 12, there was actually, compared to the standard of care group, a significant reduction in the C3 staining. So here it says 5 out of 10 patients showed a reduction in C3 staining of more than 2 orders of magnitude, and 8 of 10 patients treated with pegcetacoplan achieved more than 1 order of magnitude reduction in the staining. They had secondary endpoints as well, including proteinuria reduction. So again, there was quite a bit of proteinuria reduction in the Noble study. And then they also looked at the C3 histology activity score. And there was actually, so at week 12, C3G activity score decreased by more than 70% among 90% of the patients treated with pegcetacoplan. Again, no serious side effects, as was the case in the Discovery trial. So I'll move to the last part of my presentation with this, which is the phase 3 study. And the trial that we'll discuss is the Valiant one, which, as I said, not published yet, but it was actually already presented at the ASN meeting. So here what they did is basically they included everybody above the age of 12. They had to had a previous diagnosis, histological diagnosis of C3G or primary immune complex MPGN, and they could have been sort of native C3G immune complex MPGN or post-transplant recurrence. They had to have had a proteinuria of more than 1 gram per day. and eGFR more than 30, so the ones that are considered moderate to high risk, they needed to be treated with stable regimen, i.e. the current standard of care. And they had to have evidence of active renal disease, and this is how it was defined. So baseline biopsy needed to have more than 2 plus C3 staining. And adolescents with no baseline biopsy needed to have high plasma C5b9 levels, low C3 levels, active urinary sediment, and the presence of C3 nephritic factor. So patients were randomized 1-to-1, and this was placebo controlled. So they either received pegcetacoplan plus standard of care or placebo plus standard of care. This went on for 26 weeks, and then at 26 weeks, everybody received pegcetacoplan for another 26 weeks. So a total of 52 weeks, i.e. 1 year. And then, as I mentioned earlier, there's going to be the VALE study, which is basically a safety follow-up and extension of Valiant. So their primary endpoint was actually log transformed ratio of urine protein creatinine ratio at 26 weeks versus baseline. And then they had a bunch of secondary endpoints. The first one was the composite renal endpoint, more than 50% reduction in urine protein creatinine ratio versus baseline, C3G histological index, C3 staining, and then eGFR as well. These are their baseline characteristics. Median age was in the 20s. Baseline 24-hour urine protein was also almost in the nephrotic range, slightly higher in the pegcetacoplan group. Baseline GFR mean was 78 ml in the pegcetacoplan group and 87 in the placebo. And then in terms of the conditions, again, the majority actually has C3Gs, and only around 20% had primary immune complex MPGN, and only a minority, around 6 to 8%, were actually post-transplant recurrences. So what were the results of the Valiant trial? So in terms of proteinuria, the primary outcome, you can see that there was actually a significant reduction in proteinuria at 26 weeks. 68% reduction, which was statistically significant. And this reduction was actually observed as early as 4 weeks and continued throughout the 26-week duration of the initial part of the study. If we look at the forest plot, actually the different subgroups, all of them basically favored pegcetacoplan, and the confidence intervals were not crossing the 1. All statistically significant. If you look at the more than 50% proteinuria reduction, again, 60% versus only 5% in placebo, statistically significant. If we further subdivide, the degree of proteinuria, so the patients who achieved less than 1 gram proteinuria, remember the groups that were studied on average actually had nephrotic range proteinuria, about 3.5 to 3.8 grams per day. So for somebody's proteinuria to improve to less than 1 gram per day at 26 weeks, i.e. around 6 months, that's actually pretty remarkable. And you can see that in pegcetacoplan, almost, I would say, 42% of the patients achieved a proteinuria of less than 1 gram per day, compared to pegcetacoplan, where the number was actually only 20%. And then you can see the numbers for the 1 to 3 grams, and then more than 3 grams. If we look at the stabilization of the eGFR, so at 26 weeks, the pegcetacoplan group lost 1.5 ml of GFR versus 7.8 ml of GFR in the placebo group. So that comes to an absolute difference of 6.3 ml per minute per 1.73 meters square, which is also statistically significant. And then if we come to the histology part, which is relatively new, So they did actually protocol biopsies for these patients at 26 weeks. And there was actually also a very remarkable improvement in the C3 staining. So 71.4% of pegcetacoplan treated patients achieved actually zero intensity on repeat biopsy at around 6 months compared to placebo. So if we look at the proportion with reduced C3 staining, that was 74% in pegcetacoplan and only 11% or maybe around 12% in placebo. If we look at the composite secondary renal endpoint, again, pegcetacoplan was much better than placebo, 27 times better odds of achieving composite renal endpoint versus placebo, highly statistically significant. And if we look at the adverse effects, so again, it was actually very well tolerated, and the frequency and severity of adverse effects were similar between the two arms. The important thing is that there were no infections with encapsulated Neisseria meningitis. In total, there were 4 cases of serious infections. 3 of them were in pegcetacoplan and 1 was in the placebo. And this is consistent with more than 2,000 patient years of pegcetacoplan exposure. This is a summary of what I have already discussed. So histopathology improvement in more than 70% of pegcetacoplan treated patients, 68% reduction in proteinuria compared to placebo, eGFR stabilization, an absolute difference of 6.3 ml between the two groups. And then there were no encapsulated meningitis cases reported. And in general, it was a well-tolerated medication. So I'll end the first part of my talk by a few take-home messages on C3G and immune complex MPGN. So these conditions can result from genetic mutations or autoantibodies affecting the alternative complement pathway. But we have to keep in mind that in at least 50% of the patients, maybe even more, we actually don't know the cause or we can't pinpoint the cause. Patients can present, with a whole spectrum of presentations, microscopic hematuria and subnephrotic proteinuria, all the way to RPGN or advanced chronic kidney disease. Etiologies are heterogeneous, and these patients require a lot of homework to be done to exclude underlying cause, especially in elderly people where you really have to rule out monoclonal gammopathies. Unfortunately, existing therapies do not always prevent progressive CKD or end-stage kidney disease. However, we now have novel complement inhibitors which show promising efficacy with likely less systemic toxicity. Thank you very much.
Okay, thank you very much, Ali. Jazakallah khair. Excellent presentation. Tariq, shall we go through the questions for Ali, please, on the website?
Dr. Issa, we can delay it to the end of the sessions because actually the time is running out, so we can finish all the sessions initially, then start questions after that. Okay.
Start with Dr. Sadiq then.
Yes, Dr. Sadiq, please.
You have the presentation up. All right, now it's my pleasure to introduce my colleagues since almost now more than 35 years, Dr. Sadiq. I know Sadiq, one of the few people who can speak at least 4 languages. Sadiq, of course, graduated from Italy as undergraduate. Then, of course, he has his Royal College of Physicians of UK and pursue further training in Canada, Fellowship of Nephrology. Sadiq as well is a Fellowship Royal College of Physicians of United Kingdom, and he is one of the most senior consultant nephrologists at the Royal Hospital in the Sultanate at large. And Sadiq is very much indulged into various activity and education, both in public as well in hospital undergrad and postgrad. Sadiq, welcome, and the floor is yours.
Assalamu alaikum. Can you hear me?
Yes, we do.
Yes, okay. First of all, thanks to OSNT for giving me this opportunity to talk about this rare disease, Now, I'm glad that Dr. Ali has set the ground for me, so I'll not go to the physiopathology. I'll discuss my case. So back in 2023 November, we were referred a young gentleman, Mr. A. He was at that time 17 years old, and he was referred to us for deranged renal function and nephrotic range proteinuria. The interesting part is that 2 months prior to his presentation,
your slides, I don't know if others can see them, but I cannot.
sorry, okay, give me a second.
I can see the slides of Dr. Sadiq.
Can you see my slides?
Yes, I can see it as well.
I can see it. Yeah, I can see it as well.
Maybe I'll have to stop sharing my slides, but
Yeah.
I don't know how to do that.
So can all of you see my slides?
Let me try from my side, Dr. Ali. I will stop your sharing.
Okay.
Can you see now?
Yeah, we can see your slide.
Okay. So
yes, thank you.
okay, shall I continue?
Yes, please, thank you. Sorry about that.
So prior to, two months prior to his presentation at the Royal Hospital, he came with fever and throat pain, and that reminds me what Dr. Ali just now said, that it was thought as an infection. So he has severe headache and blurring of the vision, and his blood pressure was very high. Systolic blood pressure on the right arm was almost 200, about 125, and the left arm was the same. The referring team, the part of the Oman where he was initially treated, they did a good job. They did the initial investigation. His physical examination was normal, his fundus was normal, and he had no other comorbidities. He denied joint pain, skin rashes, Raynaud's phenomena, excessive hair loss, genital ulcers, or edema. And they also consulted the ENT surgeons and the ophthalmologist, and the examination was reported as normal. This young gentleman was not a smoker, and as per the family history, his parents were cousins. There is some renal disease, history of renal disease from his maternal side, but we don't have the details. So ultrasound was done back in his city, and it showed right and left kidney almost 10 centimeter with loss of cortical medullary differentiation, and he had hyperechoic parenchyma. There was no evidence of renal artery stenosis. His echo was also done, which showed LV, which was mildly concentric, good systolic function with ejection fraction of 71%. For some reason, maybe because of high blood pressure, headache, or blurred vision, he underwent CT head and was reported as normal. Initial workup back in his hometown showed C3 of 708, and it was low. C4 was normal. In the dipstick, he had 2+ albumin and RBC more than 60. Serum albumin was borderline 34. His creatinine was already high, almost touching 200, the GFR of 41 ml per minute. Hence, he was transferred to us at the end of October and beginning of November 2023 for biopsy. So these were the investigations which were done here at the Royal Hospital initially in November. You could see that his hemoglobin was 9.4, so he was anemic, and his serum albumin was only 20. And his GFR had dropped to 27. He had frank nephrotic proteinuria with 500 milligram per deciliter in the urine dipstick, 4 grams of proteinuria, and PCR was 484. His ASO titer was negative. His PTH was normal. His uric acid was high, 659, and his ANA was negative. Since we found that his iron saturation was low, and that will be here in the next slide. You can see 16% transferrin saturation and 8 of iron. So we give him IV iron, and that's how his hemoglobin came up to 12. But he had again same nephrotic range proteinuria. In the same month of between November and December, you can see that at the Royal Hospital, his C3 was 567, it was low, and C4 was normal. And I'll talk about the C5 and C9 in the later slides, but C5 was normal. Sorry for that. Yeah, so C5 was normal, C9 was within normal limit, and CH50 was normal. CRP was almost within normal limit, so he had no evidence of any infection. His whole panel of workup was negative. retrovirus, hepatitis B co-total non-reactive. He was immune. He had hepatitis B surface antibody, which was 26.5. HBsAg negative. C3 nephritic factor was negative. His urine culture and blood culture were both negative. Okay, so C5, like I mentioned earlier, it was within normal limit, but C9 was high. You can see the limit was between the normal limit, is between 120 and 270. It was 326. His ANCA, MPO, PR3 were negative. Anti-GBM was also negative. CH50 was within normal limit. Then we did the whole panel of other investigations. Factor H antigen was almost normal. It was 131%. Functional factor H was less than 5, as it's supposed to be. Anti-factor H antibody was 77, again within normal limit. And strangely, his alternate pathway, as per the report which was sent abroad, was 148%, and it should be less than 150%. So his alternate pathway was also within normal limit. So he underwent kidney biopsy, and I would like to invite Dr. Marwa Riyami, the senior consultant histopathologist at the SQUH, who has been very kind enough to explain the kidney biopsy. So, Dr. Marwa, are you here? Dr. Marwa? Actually, the slides were prepared by Dr. Naima, but she has gone for Umrah, so Dr. Marwa has nicely agreed, but I can't hear her. Tariq, if you can unmute for Dr. Marwa.
Assalamu alaikum jami'an.
Alaikum salam, Doctora.
Sorry, it was not allowing me to unmute myself. So
It's
yeah,
all from Tariq. It's all from Tariq.
Thank you very much, Dr. Sadiq. Yeah, and I'm happy.
Thanks to you. First of all, thanks to you. You have agreed to describe the slides.
It's okay, my pleasure. So what we have on low power here are 2 cores of renal cortex. They were a total of 25 glomeruli. Overall, looking at it on low power, the background doesn't really look too bad. Yani. The tubules seem to be back to back for the most part. Perhaps there's some focus here of atrophy and fibrosis, and in this area here as well. We'll see that a bit closer. So we can move on. Can you change the slide? Yeah, Dr. Sadiq, thank you. So here we have some glomeruli on low power. We can see here's one that's totally sclerosed. This one shows periglomerular fibrosis and also segmental sclerosis. Again, from low power, you can see that you cannot really appreciate open loops. The glomeruli look quite solid. The tubules up at the top here seem to be, back to back, so non-atrophic tubules. Here, there's an area where the tubules look a bit more separated from each other by fibrosis. They're smaller in size. And here we have an area of like dense sclerosis with inflammation. Interestingly as well, he has, I don't know if you can see the arrow or not, but down here, there are these foam cell aggregates. And these foam cells actually indicate long-standing proteinuria. Actually, there are two things that foam cells indicate. Either it's Alport or it's someone who has long-standing proteinuria. For example, in membranous or FSGS, we see these foam cells. Okay, we move on. Dr. Sadiq, yeah, thank you. Okay, so again, looking at these glomeruli, they really look very solid because they are showing a lot of mesangial matrix expansion with narrowing of the capillary loops. The normal architecture is markedly altered. This glomerulus in the middle is actually segmentally scarred, and you can see an adhesion actually between the tuft and the Bowman's capsule. Okay. Yeah, can we go to the next picture? Yeah, so looking here, again, the mesangium actually looks very pink. So if you look at the glomerulus, it really looks really very pink in its mesangium, which tells you that there is something there that is deposited in this glomerulus. There is also striking mesangial hypercellularity and also endocapillary hypercellularity. So there seems to be inflammatory cells also segmentally within capillary loops. And generally, wherever you look, you really struggle to find nicely open capillary loops. That's because their glomerular basement membranes also are really thick. So the architecture is really strikingly altered. Okay. We move on. So here's the this is the PAS stain, periodic acid shift. It's a nice stain also to help us appreciate, you know, the segmental scars, the membrane thickening. So here, just here at, you know, in the glomerulus at around 2 o'clock, no, it's more like 3 or 4 o'clock, there's a thickened capillary loop. Also down here at around 7 o'clock position, there is a thickened basement membrane, and you can almost appreciate the double contours there. And if we go to the next one, the silver stain, Dr. Sadiq, the Jones, yeah, here. So again, you can appreciate the complexity of the appearance of the basement membrane. In some places, it looks very pinkish, okay? And in others, we also see some double contour appearance, the tram track appearance to the basement membrane. And the tubules look atrophic, you know, many of the tubules beside that glomerulus. Again, just higher magnification images showing this really thickening and complexity of architecture of the glomerular basement membranes. So down at around 6, 7 o'clock position, these are normal basement membranes. You can see it's like a thin line, but if you look up at around like 12 o'clock, 11 to 12 o'clock position, these membranes are really thickened with complexity of architecture. And if you see this very bright pinkish material on the membrane, these are deposits. Next, Dr. Sadiq. Yeah, this is just the same, again, in higher magnification.
Next.
Yeah, next, please. Okay, this is just the trichrome stain. Again, it just highlights the same, shows you the collagenous matrix in the green color in the mesangium and in the basement membranes. Okay, so next. So this was, yeah, so those were the findings. This is the immunofluorescence, and it showed this very coarse granular staining for C3 in mesangial areas as well as along capillary loops. And you can see it's really coarse. Yeah, and these, you can see the actual deposits, they're big and chunky, giving you, you know, like sort of this, like a starry sky, bright sky appearance. Next. The rest were negative. So IgM there was minimal IgM, and IgA, IgG, C3, C1q, kappa lambda were all negative. IF was performed on the paraffin embedded tissue, and there were no mass deposits. So based on the LM and the IF, this was a membranoproliferative pattern of glomerulonephritis that is C3 dominant, therefore consistent with a C3 glomerulonephritis. This is the electron microscopy. We see narrowed capillary loops with inflammatory cells. The basement membranes here also look really complex in their architecture. And you don't see nice preserved podocyte foot processes over the surface of these membranes. Yeah, next, Dr. Sada. Here, just right in the center between these 4 nuclei, we can appreciate these darker areas that are mesangial deposits. So we have mesangial deposits. The basement membranes also look quite dark due to the presence of deposits within these membranes as well. And the loops are very narrowed. They're really narrowed to occluded. And no visible podocyte foot processes, in keeping with the fact that this patient has nephrotic range proteinuria. Okay, next.
Yeah, this is the next one.
Okay, now if you just look here, I really don't know if you can see my arrow or no, but there's something round, like a rounded structure, almost at around 9 p.m. Position, like a 9 o'clock position, sorry. That seems to be like a large subepithelial, a bit like a hump-like deposit on the membrane. And we have some inflammatory cells within this capillary loop. Yeah. And it's just showing more of the same low, if you go to the next one, low magnification image, just showing the markedly altered architecture of this glomerulonephritis in keeping with a chronic GN that has an MPGN pattern, mesangial deposits, intramembranous and subepithelial deposits, occasional subepithelial hump-like deposits as well. So all in all, going with a C3 glomerulonephritis. I think that's it for the pathology. Yeah, it's just more of the same.
Okay, thank you very much, Dr. Marwa, for the nice presentation of the
Right.
slides. Okay, so his initial management was that he was started on ACE inhibitor, calcium and vitamin D. Then we started him on steroids, tapering dose, and he was started really on mycophenolate mofetil along with steroids. We gave him around 5 months from December, end of December till May 2024. And we did not really see any improvement. You can see that his GFR remained at 33. He had nephrotic range proteinuria. His urine dipstick showed 500 milligram per deciliter. Urine protein was 2.7 grams per liter, and PCR was 446. Serum albumin was still on the lower side, 31. Uric acid again was on the higher side. And his C3 remained low, 625, with normal C4. At this stage, we decided to give him the second line of treatment, which was revolutimab, as we don't have eculizumab anymore at the Royal Hospital. So he was vaccinated in May 2024, but due to logistic reason, he could not get revolutimab till August 2024. So he received his first dose of revolutimab in August and in September, and then in November last year. This was in September. That was after the second dose. He continued to have low serum albumin. His urine was still showing nephrotic range proteinuria with 500 milligram in the dipstick. PCR was 306. And this was his. This was in November 2024. After the third dose of revolutimab, he continued to have nephrotic range proteinuria. Urine protein was 3.4, PCR was 733, and his serum albumin had dropped to 27, and his GFR was 50 ml per minute. At the local hospital, somewhere in January this year, he was investigated, and his urine dipstick showed 3+ protein, and this is after 3 doses of revolutimab, and creatinine was 264 with a GFR of 29 ml per minute. His potassium was 5.29, so his ACE inhibitor was held. And then he came to the Royal again, and this was yesterday or day before yesterday. And you can see till now his GFR is still 36. He still has urine dipstick of 500 milligram per DL, urine protein almost 4 grams, PCR of 680, and he had urine in the blood. Blood in the urine. So he had active sediment, and his C3 had normalized. And that was surprising for us. But in view, and his ESR was 53. So as per February 2025, he still has nephrotic range proteinuria, even though his C3 has for the first time touched the normal limit. We have done the genetic testing, was awaited, and his GFR still remains low. So we are planning to give him the C3 inhibitor, which is the pegcetacoplan, and hopefully he will improve. Thank you.
All right, thank you very much, Dr. Sadiq. Last but not least, would like to welcome my colleagues, Dr. Dastoor. I know Dastoor Hormaz since now 2009, 2010, when we met in Dubai first time. Of course, Dastoor is highly qualified with American board certified. In fact, he works in many places, United States, as well in United Kingdom, many other places, of course, and his favorite place to work is in Abu Dhabi, where he's been there since, 15, 20 years?
Long time.
Of course, Dastoor is as well quite much involved in the administrative part of the nephrology, especially in UAE, as well in education, and he has many publications, both in the epidemiology and intervention of nephrology and transplantation. So it's my pleasure and honor to welcome Dastoor. And please, Hormaz, the floor is yours. Please go ahead.
Thank you. So I don't have a lot of time, but let me go through 3 cases quickly. Maybe some will be interesting to you. So the first case is a 28-year-old male patient who was previously healthy, not known to have any chronic medical illness, no family history, no history of non-steroidals or herbal medications. So in September 2023, he presented with lower limb edema, deranged kidney function, near nephrotic range proteinuria. His urine analysis showed a few RBCs. He had a normal complements, which can happen in half the cases. And the kidneys were bilaterally echogenic, but with maintained corticomedullary differentiation. So that time he presented in a private clinic. He had a biopsy done. We were able to get screenshots of the biopsy results, so it's not very clear, but you can basically see that there were a lot of C3 deposits, and the amount of interstitial fibrosis and was around 30%. So at that time, he was treated based on the KDIGO guidelines in the private sector with IV steroids and cyclophosphamide and plasmapheresis. By March 2024, his kidney function did not improve. He had about 400 micromoles. His kidney function was around 400 micromoles. He had a second kidney biopsy, which showed even worse C3 deposits and about 40% IFTA now. So he was continued on steroids, and we continued him on MMF. By April, his renal function declined to around 550 micromoles. And at that time, there were no other options left for him. So we decided to start him on rescue therapy with pegcetacoplan. So as you can see from his labs, there was an initial decline in his kidney function, but then slowly, his kidney function started to increase. I also want to highlight that between April, when we made a decision to start him on pegcetacoplan, and by the time we started, actually got the approvals and got the medications, we wasted around 3 months, you know. So in that time, obviously his kidney function had declined. His protein creatinine ratio initially showed some improvement. You can see that initially there was an improvement in his protein creatinine ratio, but then obviously it became worse. Now you can also see that we stopped the C3 pathway because as soon as we gave him the pegcetacoplan, his C3 levels jumped. Yeah, so there was a complete block in the C3 pathway. So in August, when his kidney function declined, we were kind of confused, like what is happening with this guy? You know, is there a worsening of his IFTA and progression to ESRD? Does he have a component of ATN? Was there some interstitial nephritis? So at our center, we decided to do a kidney biopsy. And in the kidney biopsy, we found something strange. First of all, the C3 deposits, you can see the intensity of the C3 deposits had declined significantly. So just like in the Valiant trial, where you see a 2-order magnitude of decline in the C3 deposits, this is what we saw. But interestingly, what we saw is that there were these new deposits of IgA. So we went back to the first 2 biopsy reports, and we saw that in those reports, there were no IgA deposits at all. So these are something new. So the question that arose was, number one, we had 2 questions. Number one, how did he go from a diagnosis of pure C3 to a diagnosis of IgA nephropathy? Because our pathologist read this as an IgA nephropathy. In the absence of significant C3 deposits, he read it as an IgA nephropathy with M1, T2, C1. So the questions that we put to ourselves was it justifiable to use a complement inhibitor in this patient? And in hindsight, yes, because this patient actually had a C3 nephropathy. He had a very aggressive course. We had no treatment options for him, and we decided to use rescue therapy. At the time we decided to use rescue therapy, he met all the guidelines for inclusion into the Valiant trial. And his IFTA was around 30 to 40%, and that is why we included him in the trial. Should we have done a 3rd biopsy before starting? I think that was an error that we made because of the gap of 3 months and there was a decline in his kidney function. We should have done a biopsy prior to starting pegcetacoplan because though his creatinine increased from 400 to 500 before we started pegcetacoplan, in his biopsy, by this time, there was actually 90% IFTA. So he moved from 40% IFTA in 3 months to 90% IFTA. So this patient had a very, very aggressive form of disease. I think if we had caught this patient in September 2023, when he had his initial presentation, and given him the pegcetacoplan, we would have had a different outcome. Unfortunately, we only had pegcetacoplan available in May of last year, and we possibly started it very late, and that is why we did not see success. But I know that he would have had success if we started earlier, because in the glomeruli, which was still viable, he had more or less complete resolution of the C3 deposits. So what we learned from this case is when you diagnose C3 glomerulopathy, I know that the KDIGO guidelines suggest to use MMF and steroids. And you saw from the first lecture that the success rate with MMF and steroids is less than 30%. I think the treatment guidelines will change, and you really need to be more aggressive in your patients and start them on pegcetacoplan much earlier than starting them on MMF and steroids and hoping for a favorable outcome. Now, the second case is a 20-year-old male patient who presented with nephrotic syndrome. He works as a policeman. He doesn't have any family history of any kidney disease, no recent infections. He may have had a mild facial rash. He presented with serum creatinine of 134, around an active urinary sediment, hypoalbuminemia, urine protein creatinine ratio of 7 grams. His ANA was positive, about 1:160. His histone was positive. Double-strand DNA, serum protein electrophoresis, and all other immunologic markers were negative. He had a kidney biopsy. The kidney biopsy showed that he had an MPGN pattern of injury. He had kind of like a full house pattern with C1q and C3 deposits. Our pathologist, based upon the positive ANA and the C3, C1q deposits, read it as a lupus nephritis. We also checked his C2 levels and C2 activity, because usually when ANA is positive and double-strand DNA is negative, there is a possibility of C2 deficient lupus nephritis, but that was ruled out. Because of his unusual histologic presentation, we decided to do more genetic studies, and the genetic studies came back positive for complement factor HR1 positive and HR3 positive mutation, and his C3 nephritic factor came back positive. We did his complement panel, and the complement panel was suggestive of alternate pathway activation because his AH was less than 10% and C5b9 was greater than 1200. So if you put the picture together, right, you don't need a biopsy. And you saw in the Valiant trial, if you have young adolescents, you don't need to do a kidney biopsy. So if you put his clinical picture together, he is a patient with deranged kidney function, nephrotic range proteinuria, activation of the complement pathway as suggested by low AH50, elevated C5b9, decrease in complement C3, and positive C3 nephritic factor and an active urinary sediment. He meets all the criteria of activity in the of the alternate pathway of the complement system. So based upon this, our final diagnosis actually was this patient has a full house pattern, but this is not due to lupus. In fact, this is immune complex mediated MPGN with activation of the alternate pathway. The etiology of his disease is a C3 nephritic factor with possible variants of unknown significance of complement factor HR1 and 3. The trigger in this patient is unclear. Maybe he had an infection, he's not aware. And the patient is a strong consideration for anti-complement therapy. In fact, we have submitted to our PTC committee for anti-complement therapy. My understanding is he will be approved for it, so we are waiting to see how he will respond to pegcetacoplan. And the third and final case is a 50-year-old man from Syria. He's known diabetic for type 2, but very well controlled. Hemoglobin A1C is around 5.1. He has a history of gout and renal stones. He was admitted with vomiting and renal failure, serum creatinine of 240. Urine creatinine ratio was 1.9. RBC was positive in the urine. His serology was completely normal. Prior to biopsy, I would say this is an IgA nephropathy. But he had a kidney biopsy showing an MPG pattern of injury, and you can see the silver staining as well for the glomerular basement membrane. His C3 deposits were present. Our pathologist actually read it as 2+ positive, and he diagnosed it as C3 glomerulopathy. Okay, so this patient basically did not qualify for pegcetacoplan given his insurance and his non-national status. So we decided to follow the KDIGO guidelines. We started him on, between May and October, we started him on steroids, mycophenolate, SGLT2, ARBs, and MRA. And surprisingly, beyond my expectations, there was an improvement in his eGFR and the proteinuria. So out of curiosity, the question was, did his eGFR and proteinuria improve because of the SGLT2, ARBs, or MRAs? Or did it actually, was there a reduction in the C3 deposit? So we decided out of curiosity to do a biopsy. And in the biopsy, surprisingly, he had an actual reduction in his C3 deposits. So at that time, we did not see any role for a pegcetacoplan or any complement therapy. That was up till October. Then you can see that after October, where he had an improvement in his GFR and RBC count and an improvement in his C3 status, after October, there was a reversal. His protein creatinine ratio started to increase. It became nephrotic. His serum creatinine after October also started to rise. It then came down, but now he's rising again. His latest serum creatinine just about a week ago is around 320 micromoles. And you can see that after an initial improvement in his eGFR, there was a decrease in his eGFR, slight improvement, and again a decrease in his GFR. So basically, he was kind of borderline showing an improvement with the MMF and steroids, but he is at high risk of progression of his disease, just like patient number 1. And we recommended to our PTC committee to consider anti-complement therapy. And I'm hoping that despite his insurance and despite his non-national status, he will be approved for anti-complement therapy, because we don't want to end up like the first case where the patient rapidly progresses to end-stage renal disease and will require dialysis. So these are our 3 cases. We actually have another active patient who is doing quite well on pegcetacoplan. So we have 4 potential patients for pegcetacoplan therapy. Thank you.
اوكي ثانك يو طارق. اوكي علي حبيبي تفضل جزاك الله خير.
Thank you very much, Dr. Tariq, Dr. Issa. We've already had fascinating cases, but I have one, potentially 2 more cases to discuss that I've come across in my practice. So the first one is a 20-year-old man who was feeling relatively fine. And in fact, he was actually applying to join the police forces. There they did the basic blood work, and they found him to be severely anemic. Hemoglobin was 7 grams per deciliter. So they actually referred him to local health center. They obviously declined him, and they told him, go to local health center and figure out what's going on. So in the local health center and subsequently polyclinic, his creatinine was found to be more than 600 with microscopic hematuria and proteinuria and very low C3. So in my hospital, the lower normal limit of C3 is 0.9, as you can see, his initial one was actually 0.2. So he was referred to the regional to a tertiary hospital, where a renal biopsy was immediately performed, and it confirmed C3 glomerulonephritis, unfortunately with 90% IFTA. And actually, within a few weeks, he had to be started on peritoneal dialysis. And then his further workup, as expected, confirmed complement dysregulation, both serologically and genetics. So this is a screenshot of his alternative complement pathway testing, which we sent to Mayo Clinic. And you can see that his complement factor 5B9 was more than 1,200. His anti-factor H IgG was normal, 51, the normal being less than 60. And then we did the genetic testing for him, which actually showed a heterozygous large deletion encompassing the entire gene of complement factor H related factor 1 and 3. And by the way, this is from my practice, this is the most common mutation I'm seeing here in Oman. I don't know if that's similar to other countries as well. So my first encounter with him was in 2018. By that time, he was already on PD for about 3 or 4 years. And he was referred to me for kidney transplant with his brother being the potential donor. His brother was completely healthy and actually turned out to be, actually matched, a fully matched sibling. And when he came to me, he was very skeptical because someone at some point had already told him that the risk of recurrence is high, and he was actually kind of discouraged from going for kidney transplant. And we know that when the risk of recurrence is high, and when there is recurrence, the median time to end-stage kidney disease is 7 years. Plus, we know that there are risk factors for post-transplant recurrence, which is low C3, high level of autoantibodies, rapid progression to end-stage kidney disease in native kidneys, and a living transplant. And this particular patient had at least 2 out of the 4 risk factors, possibly 3 actually, if we consider rapid progression to end-stage kidney disease. So these are the questions that came to my mind, and we can discuss them further later. Would you transplant him? And before transplanting him, will you give him eculizumab or other complement blockers preemptively in an attempt to mitigate the risk of recurrence? So I'm going to tell you what we did actually with him. I had no idea what to do. So I actually consulted one of my mentors during my fellowship. I'm sure many of you are familiar with him, Dr. Daniel Katran. And his reply was, we don't know if eculizumab will help, but if you have access to it, maybe try and see. And maybe it will, theoretically can reduce the risk of recurrence. So based on that advice, and in 2019, actually, it was much easier to access eculizumab than it is now. So I was able to arrange it for him, and he was treated with eculizumab from January 2019 to April 2019. If you see his C3 trend, it was like 0.3, 0.4, and as low as 0.2. And then we started him on eculizumab in January. And then in February, his C3 was 0.48. And then just before the transplant, it was 0.59. So there was a modest improvement in his C3 level with terminal complement blockade. He underwent the kidney transplant after, counseling him thoroughly about all the risks. Had a bit of DGF and needed dialysis for a couple of days post-transplant, but then subsequently opened up, and his creatinine improved all the way down to 70. 8 weeks post-transplant, he developed an acute illness, some abdominal pain, vomiting, and with that, he had an acute kidney injury with creatinine that was 140. And it didn't improve like after, treatment of his underlying acute illness and volume repletion. So, knowing the risk of recurrent C3G is high, I performed a biopsy, and this was the report of his kidney biopsy. 4 out of 19 glomes were obsolete, probably donor related. There was no proliferation. There was mild focal and segmented increase in mesangial matrix and cells, but no endocapillary proliferation, no glomerulitis, there was some acute tubular injury. And then the immunofluorescence, which had 9 gloms, showed actually scanty segmental mesangial staining for C3+. There was no staining for other immunoglobulins and complements. So the final impression was ATN, no evidence of rejection, scanty C3 on immunofluorescence, but no deposits were seen on EM, although on light microscopy, there was some mesangial proliferation, and there was no IFTA. So at that time, his C3 was normal. He had no proteinuria. And after the biopsy, his creatinine ultimately recovered back to baseline. So clearly it was all ATN. But with that, scanty C3 deposition on his graft biopsy in a patient who's at very high risk of recurrence, would you have considered giving him a complement blocker? So I'll end this case by mentioning the current status of the patient. Obviously, I did not give him eculizumab at that point. He is now, in April, he's going to be 6 years post-transplant, a normal graft function, no hematuria, no proteinuria, and his C3 remains normal. And I wanted to show you the trend of his C3 levels. So if you remember, when I gave him pre-transplant eculizumab, his C3 improved up to 0.54, although the treatment duration was about 2 months. But then immediately post-transplant, his actually C3 normalized, and it remains normal to this date. And likely it's the effect of the standard post-transplant immunosuppression, the steroids, mycophenolate, and CNI. So I think that was a very interesting lesson that I learned from this patient. And then my second and last case is a 32-year-old healthy bodybuilder, no known medical problems. He presented to the emergency department with progressive leg edema and frothy urine. He also gave a history of feeling feverish for the past few weeks, although fever, temperature was never documented, as well as a diffuse rash in his body. Clinically looked well, but he was hypertensive. He had 1+ edema bilaterally. A small cervical lymph node was noted, and he had a diffuse macular rash. Those were his initial labs. So albumin was 24, creatinine peak was 185. Hemoglobin A1C was normal. Urine microscopy showed, numerous RBCs. Urine dipstick showed protein 500 milligrams per deciliter. Urine protein creatinine ratio was 350, so nephrotic range. And his C3 was low at 604, the normal being more than 850. ANA and anti-GBM were negative. HIV, chronic hep screen were negative. Syphilis was also sent, which was pending. And he had a biopsy. This was not where I practice. It was in another hospital. So actually a biopsy was already arranged. He had 23 gloms, non-obsolete. All biopsies showed increase in intracapillary inflammatory cells, which I think was one clue. 2 gloms had crescents, and there was segmental increase in mesangial matrix and cellularity. Capillary walls were also segmentally thickened with occasional double contour. So it sounds like MPGN. And then on immunofluorescence, he actually had 3+ C3 deposition with no staining documented for IgG or actually any other immunoglobulins or kappa and lambda. And then on electron microscopy, what was the interesting finding is that he had few subepithelial hump-like immune complex deposits. And then he also had some mesangial and paramesangial deposits as well. So the ultimate impression of the pathologist was mesangial and endocapillary proliferative GN with crescents and isolated C3 deposition. The overall features could represent a form of dysregulation alternative pathway, kindly correlate with biochemical tests. So actually, I don't remember the details of what happened later, but somehow this patient ended up with me. And I repeated his biopsies. And at this point of time, I apologize. I actually don't remember what was the indication of repeating a biopsy. I think maybe I did not have access to this report. So obviously I needed to know what's going on. His creatinine was 188 at that point. So we repeated his biopsy in my hospital. None of the 10 gloms were obsolete. Again, he had moderate to marked global mesangial hypercellularity, an increase in matrix, 2 fibrous crescents, seemed like the previous biopsy. But here there was no capillary wall thickness, double contours, or spikes walls. IFTA 5%, and then here also he had C3 mesangial, granular mesangial C3 staining, albeit at lower intensity, and everything else was negative. And then on electron microscopy, he had subendothelial deposits, as well as paramesangial deposits as well. So the final impression was mesangial proliferative GN. IF profile was consistent with C3 glomerulonephritis, few mesangial and subendothelial deposits on EM, mild IFTA. So obviously we had the impression at that time, it sounded like a C3GN with a picture of RPGN, which normally we have to treat aggressively. But while we are waiting for his workup, the microbiologist calls me one day and tells me, his syphilis titers are one of the highest they've ever actually seen, which is consistent with an active infection. So obviously, we consult the infectious disease team. He gets started on the usual intramuscular penicillin G protocol. And then within a few weeks, with no additional treatment, his creatinine improves all the way down to 108, which I think for him being supramuscular is pretty normal. And his urine protein creatinine ratio, it took months for his proteinuria to completely resolve. But if you remember, initially he had nephrotic range proteinuria. Now his protein creatinine ratio was 5, normal being less than 15. So a complete resolution of his glomerulonephritis. Out of curiosity, I actually did send a sample to Mayo Clinic for complement dysregulation testing. And as you can see, everything is in black. So he had no evidence of complement dysregulation. I did not do genetic testing at that time. And we've been following him now for, I would say, 3 years, and everything is pristine. No microscopic hematuria, no proteinuria. Creatinine is in that range of 110 to 120, which, most likely is not bad for someone like him. So the questions that I had during, his follow-ups were, is this really C3GN, or is it infectious GN, or is it both, like an infection triggering a C3GN? And in his case, we found an underlying cause, treated with a remarkable response. But let's say if there was no underlying cause found, would you have treated him with immunosuppression? And if yes, what would have been your choice? And then the final question is whether genetic testing is indicated in him. Thank you very much. That's all.
Thank you very much, Ali. Okay, Tara, we'll go for the question. Can you see the chat, please?